Good afternoon, everyone. This is smoking-related lung injury, and I'm Annie Frazier. Again, I have to acknowledge as part of my talk the expertise of my pathology colleagues Alan Burke and Terry Franks. We'll review how a broad spectrum of smoking-related lung injury can variably coexist in the same person. I'm going to touch on two categories, the inflammatory forms of lung injury in smokers and the irreversible or more permanent forms of lung remodeling secondary to smoking. And I will mention the new appreciation for the high sensitivity of CT imaging versus pulmonary function testing in the early diagnosis of COPD patients. It's no secret that the marketing divisions of major tobacco companies systematically and aggressively sought to use the authority and the prestige of physicians, especially otolaryngologists and dentists. And unfortunately, many doctors accepted these lucrative offers and promoted health benefits for smoking particular brands, including improving cough and throat irritation and even smoker's breath. They also targeted women directly by framing smoking as a tool for weight loss and personal beauty, and there was a flood of advertisements, which I well remember, for feminine-styled cigarettes during the women's liberation movement of the 1960s and 70s. Cigarette smoke is certainly a poisonous brew. One puff contains millions of water droplets, just packed with gaseous and particulate components, toxic particles that include tobacco nitrosamines, nicotine, aromatic hydrocarbons, heavy metals, and yes, chemicals for aroma and taste, none of which should be considered safe. And the size and weight of the particles definitely determine how far out into your airways the particulates will go before deposition. We really want to focus now on the fine and ultrafine particles, which precipitate out into the terminal, transitional, and respiratory bronchioles. Essentially, that's the centrolobular core of your secondary pulmonary lobule. And this is grand central for the key points of inflammation in smoking-induced lung injury. As we explore this topic, I'm going to be referring to important articles that are being written, not only in radiology, but also pulmonary medicine and pathology, of course. This one is an important article that's been written on the pathogenesis of COPD. It all begins with direct and immediate tissue damage by oxidative and thermal stresses that are presented by that poisonous brew of cigarette smoke and inhalation. There is an immediate immune response with inflammation that is sort of multi-pronged. Mucociliary clearance, the exudation of plasma, mucoid material, activation of macrophages along with neutrophils and lymphocytes, the enhancement of lymphoid follicle activity. And in some people, there's also activation of antigen-presenting cells or so-called pulmonary Langerhans cells. The fields of pathology, medicine, and radiology together have created a nice collection of discrete categories for smoking-related lung injury. But the reality is that there is a tremendous amount of overlap in the same patient. Potentially any or all of these entities can coexist in one person. This is my active inflammatory triad. Respiratory bronchiolitis is the center of it all, but we also have other conditions that may coexist or overlap with RB, including desquamative interstitial pneumonia and pulmonary Langerhans cell histiocytosis, and we'll cover these entities in a moment. In addition, we have to think about the more irreversible and permanent changes induced by smoking, including emphysema, smoking-related fibrosis, and even the entities of pulmonary fibrosis, vascular diseases, including accelerated atherosclerosis and pulmonary hypertension, as well as neoplasia in the chest. So let's begin with smoker's bronchiolitis. It's found on virtually 100% of all smokers' pathology specimens. It is almost always asymptomatic, unless we're talking about RB-ILD, which I'll mention in a minute. It's characterized by macrophages, which we call smoker's macrophages, recruited to the respiratory bronchioles and adjacent alveoli in the face of smoking exposure. And it's potentially reversible, as I've mentioned. Classic respiratory bronchiolitis should have widespread centrolobular ground glass nodules. They may be ill-defined, they may be very faint to your eye. They're usually more densely concentrated in the upper lobes. A smoker's macrophage is almost pathognomonic for small airway-centered inflammation in a smoker. A smoker's macrophage appears to have this dusty red fine pigment in its cytoplasm, as you can see in this high-power view on the left. These macrophages are packed with hemosiderin pigment as well as the aerosolized particulates from inhaled smoke. They congregate within the distal small airways and also in the adjacent alveolar spaces. And this reflects this ongoing, sustained, airway-centered inflammatory response that nevertheless is potentially reversible. Now, the term RB-ILD, respiratory bronchiolitis interstitial lung disease, is not a pure radiologic diagnosis. In the literature, it is called the clinico-pathologic designation, and it is seen in a subgroup of smokers, current or prior, usually in the middle age, that have some symptomatology that is attributed to smoking. And on pathology, RB can be found, as well as often some features of subtle interstitial fibrosis. Unfortunately, the pulmonary function tests are not particularly reliable. So, in summary, not a radiologic diagnosis. Now, desquamative interstitial pneumonia is definitely an overlapping category with respiratory bronchiolitis. We see that the imaging pattern is a little different. There are widespread bilateral ground glass opacities, in this case scattered areas of lobular sparing. The findings are not necessarily centered in upper lobes. The distribution may be more mid to lower lung zones. And notice there really isn't a centrolobular pattern. Now, DIP, as we call it, is a misnomer. It was originally described by a famous pathologist decades ago. His name was Liebau. He felt that this DIP under the microscope was alveolar cells that were literally falling into or desquamating into the alveolar spaces. But what we know now is that this really is also just reflecting the presence of extensive smokers' macrophages. So nothing is desquamating here. Now, the DIP pathology is not exclusive to smoking. So RB, we always associate with smoking. DIP, we can see it in smokers. Up to about 90% of cases of DIP are smokers with an age range of 4th to 6th decade. But DIP can also be found in connective tissue disease-associated ILDs, infections, drug reactions, dust exposures. Unlike an RB case, these patients can have a reduced diffusion capacity on PFTs, and as I've stated, the distribution of findings and the pattern of ground glass opacities is different from RB. In general, many think that DIP and RB are on a continuum of lung injury. But there are distinctions that help us. One, DIP patients tend to be symptomatic with abnormal PFDs, reduced diffusing capacity. Remember, RB patients are not symptomatic usually. As I said, DIP inflammation probably on a continuum of much more severe infiltration of smokers' macrophages in alveolar spaces. And also, DIP imaging is a little different, as I've showed you. Multilobar and geographic zones of ground glass opacity in either all 5 lobes or middle to lower lung zones, versus RB, which is ill-defined, hazy, cloud-like centrolobular nodules that tend to be more severely distributed in upper lobes, and there's no real explanation for that difference. The other interesting thing about DIP that we don't see in RB is that a DIP case can evolve into nonspecific interstitial pneumonia pattern imaging. In that case, along with the ground glass opacities, we may see the features of fibrosis, which include reticulation, traction bronchiectasis, and bronchioloectasis, and even a few scattered cysts. On path, we're going to see lots of smokers' macrophages, but the sign of NSIP is that the alveolar walls are no longer delicate and thin, but now are thickened by collagen deposition. And that's the feature under the microscope of NSIP. Now, pulmonary Langerhans cell histiocytosis, or PLCH, is a very unusual immune response to the antigens that are found in inhaled tobacco smoke. This is a CT MIP to your right, which nicely demonstrates that PLCH is a little bit different than the RB pattern as well, because these nodules are either solid and well circumscribed, or solid and spiculated, or solid and may have some central lucency, so not that hazy centrolobular ground glass of RB. This is almost exclusively found in cigarette smokers in the 20 to 40-year-old age range, and most are symptomatic with cough and dyspnea. If a patient practices smoking cessation, this is a potentially reversible disease. The older terms for this disease, you might know, are eosinophilic granuloma, or also histiocytosis X in children. Now, based on some great research that has been done in recent years by looking at microhistology in 3 dimensions, we can now put together the fact that pulmonary Langerhans cell histiocytosis has sort of a gradual progression in the pathogenesis of this disease. It really begins as bronchiolocentric, dense nodules. These nodules can be rounded or they can be spiculated. They're very much centered around the small airways. As the disease progresses, the lesion becomes slightly more fibrotic, less cellular, and these nodules, with their features of fibrosis, start to pull open or pull apart the airways. There's also some cellular infiltration into the extending peribronchiolar alveolar walls. And then there's more of the late stage, or what some may call burnt out PLCH. And in this case, the nodules really have completely transitioned to fibrotic scars. They're called stellate scars by the pathologists. And these are fibrotic lesions. There's really no residual diagnostic in Langerhans cells left, but these fibrotic stellate scars are exerting traction on adjacent airways. So we also begin to see cystic spaces due to pericicatricial emphysema, as well as some residual cystic spaces that may be thick-walled, and that's really representing the residual, diseased, and poorly remodeled bronchiole. We can see on a microscopic specimen in the bottom right that there can be a blend of cysts and PLCH nodules. Those cysts, as you have read probably in articles and books, can be bizarrely shaped. Well, that's because the cysts aren't necessarily discrete, rounded, or spherical shapes. They're really those diseased and ectatic bronchioles. So the bizarre shapes are because we are now cutting in and out of the plane of diseased airways. Very late stage PLCH looks very similar to emphysema, where you have limited stellate scars left behind, but there's pericicatricial emphysema, perhaps some adjacent dilated airways, but it's all blending in to a background of emphysematous spaces. Under a microscope, the pathologist will see stellate scars on a background of pericicatricial and straightforward emphysema. This gross lung specimen on the left is also showing you that it would be very difficult for a pathologist to look at that gross specimen, just like it would be difficult for us to look at the CT and discern where emphysema ends and burned out PLCH with pericicatricial emphysema begins. Now, very late PLCH, as you can imagine, you go on to have risks like pneumothorax or hyperinflation. And these are 3 different cases of what we would call very severe end-stage PLCH or cystic PLCH. This case on the left is a 53-year-old physician with a long-standing smoking history who presented with several years of a non-productive cough. And when other things were excluded, like active infection that might be mycobacterial, they went on to say, stop smoking. And within 3 years, his lungs look like this on the right. So we've touched on the major inflammatory and reversible forms of smoking-related lung injury, but now let's turn to the more irreversible alterations that occur in the pulmonary anatomy with smoking. This collection of articles just begins to affirm that spirometry, or pulmonary function testing, which is routinely used in the assessment of COPD patients, vastly underestimates the severity of the damage to lung structure and function. Why do I bring this up? Because CT is really important. Emphysema on CT in early smokers actually does predict structural and physiologic disease progression and severity, even in the presence of normal spirometry. We'll begin with an important article that highlights the fact that CT imaging can reveal significant parenchymal and airway-centered damage in smokers well before those pulmonary function tests, which are really so heavily relied upon for the diagnosis of COPD. So this article was really created to address that shortcoming and to provide imagers with a sort of paradigm of CT imaging findings that line up with the well-recognized structural and functional subtypes or expressions of COPD. And here's the overview of the Fleischner classification, where we can have what may appear to be a normal central lobular anatomy, and then next look at how central lobular emphysema is expressed as clearly centroacinar or centralobular destruction of peribronchiolar alveolar walls. You know more about panlobular and paraseptal forms of emphysema as well. Central lobular emphysema, which leads to peribronchiolar alveolar wall disintegration, is really secondary to severe small airways, inflammation and remodeling. And all the factors at work may include proteases and nitrogen and oxygen radicals from the cigarette smoke, inflammatory cytokines, macrophage activity, and even genetics. These are all drivers of this process. So emphysema is really a disintegration or a destruction of those alveolar walls that are centered around respiratory bronchioles, leading to an abnormal enlargement of those adjacent air spaces. And it's just like you took multiple scissors and started to cut apart a beautiful three-dimensional kind of fishnet architecture of interconnected and interlocking alveolar walls. And this really has a very important function in terms of suspending the architecture of the distal small airways. If we have emphysema around a distal small airways, there can be distortion, a loss of airway stability, changes in distal airway luminal patency, and overall a loss of what's called peribronchiolar elastic recoil, which begins to limit airflow in this location. So central lobular emphysema should be visualized as multifocal zones of low attenuation, chiefly upper lobes, no perceptible walls unless there's some kind of superimposed disease state like infection or edema or fibrosis. Lung volumes are normally preserved or increased in the presence of emphysema, and that has something to do with what I hinted at. That loss of elastic recoil leads to a lot of air trapping related to distal small airways. And on the left is a historical picture for you. It's a parasagittal thin lung section mounted on paper, and this is how the pathologist used to take a look at the gross anatomy of lungs, either on autopsy or in explant specimens. And in the upper lobes, you can see these large white areas where there's literally a melting away of the central lobular architecture. This is intraacinar emphysema. On the right is a gross specimen in a different case of somebody with widespread central lobular emphysema. And what it looks like is a very spongy, porous, or spiderweb appearance. That's what it looks like to the naked eye. An important point to make about watching your emphysematous spaces carefully is that we know if you see a focal area of asymmetric wall thickening or a developing, suspicious-looking nodular opacity that is directly adjacent to the wall of an emphysematous space, you should be concerned for the potential of a developing malignancy. Now, there's certainly a differential diagnosis to that. If you see wall thickening of an emphysematous space, could it be inflammatory? Or if we see multifocal areas of cystic spaces with thickened wall margins, maybe you think about a vasculitis, but that would be in the appropriate clinical context. So smokers are at much higher risk than non-smokers for these pericystic lung cancers, and PET may not be entirely reliable. So I just wanted to bring this up, that if you see a very focal asymmetric zone of emphysematous space wall thickening or nodularity, think about the potential for a developing malignancy. Now, in the few moments we have left, I just want to touch on the topic of smoking and fibrosis. Now, there's one form of fibrosis that we associate with active inflammation related to smoking. This tends to be termed smoking-related interstitial fibrosis, and it's characterized by the laying down of collagen lining the emphysematous spaces or enlarged air spaces in the upper lobes. We also, however, know that there is a predisposition towards fibrotic interstitial lung disease, especially IPF, in the smoking population. And in some unusual cases, we know that patients may actually present with a combination of both findings of emphysema and bibasilar features of prominent interstitial fibrosis. This is a mashup drawing just to give you that idea. So this is a patient, a heavy smoker, elderly male, increasing hypoxia, and this is a case that ultimately went to my ILD conference. But we have a combination of upper lobe emphysematous spaces, some of which have perceptible walls, combined with lower lobe volume loss, areas of honeycombing, and reticulation. Lung biopsy showed a combination of emphysema and UIP. This is a case of combined pulmonary fibrosis and emphysema, which can arise in older male smokers with high PAC years. Although they may have declining functional and lung status, they actually have a false normalization of their PFTs in some cases. Notice that the upper lobe volumes are normal to increase as you would expect in a COPD patient, and yet the lower lobes demonstrate a diminished volume, which you would not suspect in straightforward COPD with features that are suggesting fibrosis, including honeycombing and reticulation. These patients are really carrying two different diagnoses, COPD related to smoking, plus a fibrotic diffuse ILD, in this case UIP-IPF. Likely there's some synergy involved here. It's important to try and identify these patients because compared to COPD patients alone, these patients will have a lower 5-year survival, more limits on gas exchange, higher risk of developing pulmonary hypertension, and a higher risk of developing lung cancer. And so here is a different case of CPFE. A patient that was diagnosed 1 year ago is re-imaged and a juxtapleural left lower lobe nodule is found, which turned out to be PET-positive primary lung cancer. All right, so we're finished with smoking-related lung injury. Thank you so much for your attention. I hope you have a great vacation time in Disney. And just remember, this is how radiologists party. Take care and get home safe. Bye now.